Good morning, everybody. Today, our department will be presenting CGR on tropical infection in ICU. So, I will start with the introduction, followed by my team will present the 6 challenging cases, followed by data on tropical infection in our ICU of last 4 years data, and followed by review of literature. So, tropical infections are defined as infections that are prevalent or unique to the tropical and subtropical regions. Tropical infections contribute overall 20% of all ICU admissions. INDICAP's 2 study was conducted by a National Society of Critical Care Medicine, which showed that 2.9% of the admissions are tropical infections, and out of them, 18.5% were the mortality. In the monsoon months, 80% of ICU beds are occupied by the patients of tropical infections. So, common syndromes of tropical infection in ICU are: if the patient presents with fever with respiratory symptom, it can be leptospira, malaria, scrub typhus, or melioidosis. If patient presents with the fever with encephalopathy, it can be viral encephalitis, cerebral malaria, leptospirosis, or scrub typhus. If patient presents with fever and jaundice, it can be acute viral hepatitis, leptospirosis, malaria, or scrub typhus, or yellow fever. If patient presents with shock, it can be a dengue shock syndrome, algid malaria, typhoid fever, or cholera. If it is a hemorrhagic fever, it can be a dengue, Ebola, yellow fever, malaria, or leptospira. And if the patient presents with the fever and rashes, it can be dengue, chikungunya, rickettsial fever, meningococcemia, or viral hemorrhagic fever. Now I will invite Dr. Trimurtulu for the next 2 case presentations.
Good morning, respected teachers and colleagues. I am presenting the next 2 cases. The first case was an 18-year-old female presented to the hospital with the complaints of fever, vomiting, abdominal pain. The evaluation in the local hospital found to have a dengue NS1 antigen positive and with a deranged LFT, and ultrasound is showing hepatomegaly and serositis symptoms. As there is no improvement on conservative management, patient was shifted to the admitted in the private hospital on day 7 of illness, and where the patient had a circulatory shock and bilateral pleural effusion, and ascites on drainage showing the hemorrhagic ascites, and a fever spikes with bicytopenia and coagulopathy, requiring 61 transfusions. And as there is no further improvement, patient was referred to the SGPGI, and patient was admitted in post-op ICU on day 27, and where the in view of ultrasensory CT brain was done, which was normal, and circulatory vasopressor supports were continued. In view of worsening of this respiratory failure, non-invasive ventilation was initiated, and on ascitic tapping showing the hemorrhagic ascites, and the patient continues to have a fever spikes with bicytopenia and coagulopathy, requiring 18 transfusions in the 4 days. And patient was shifted to CCM ICU on day 30. Issues at admission were circulatory shock, respiratory failure, gross ascites with intra-abdominal hypertension, bicytopenia with coagulopathy. And ICU severity scores at admission were sequential organ failure assessment score 11, acute physiology and chronic health evaluation score 25. Provisional diagnosis was sequelae of severe dengue with multi-organ dysfunction, including shock, respiratory failure, hepatitis, and coagulopathy. On the first day, in view of circulatory shock and respiratory failure with the PaO2 FiO2 ratio 160, patient was intubated. In view of abdominal distension and raised intra-abdominal pressure, abdominal drains were placed, which are showing the hemorrhagic ascites. And within the initial 1 week, patient has a high drain output, which was all hemorrhagic. And apart from that, patient had a bloodstream infection of Klebsiella and Candidemia, which was treated as per culture sensitivity. And patient has a bicytopenia and coagulopathy. And in the next 2 weeks, still patient has a persistent high drain output, which was previously not infective and currently it become infective with Enterobacter cloacae, which was treated as per culture sensitivity. Despite of 55 days of illness, patient still having the infected ascitic fluid with multiple septations on routine ultrasonic assessment, and hence we are going with the CT abdomen, which is showing multiple septations and cecal thickening. And colonoscopy was done, and which is suggestive of infective colitis, and the biopsy taken during this colonoscopy was normal, and injection streptokinase was instilled into the ascitic cavity. Apart from that, patient had a fever spikes with bicytopenia, and bone marrow was done, which is suggestive of hemophagocytic lymphohistiocytosis. As there is a uncontrolled infection, and that's why we couldn't give the steroids, and we continued the conservative management. And gradually cell lines were improved. And here you can see the acidic fluid, massive ascites in the initial days of presentation, and gradually as the days progresses, there is increase in the septations. And if you see the average ascitic drainage throughout our hospital course, we couldn't know the exact duration amount of ascitic drainage during the private hospital stay, but during the ICU CCM stay, almost 2,900 ml per day was drained, and which was initial first week was hemorrhagic. Later gradually it was decreased. And if you see the total amount of acidic drainage was 47 liters during the CCM stay, which was managed with the albumin blood products, including the 17 PRBC and after 13 FFP. And one more interesting thing is during the initial presentation in the private hospital, before blood transfusion, her blood group was AB positive. And within this 1 month, patient was received almost 80 transfusions. And later, patient when present to the CCM ICU, there is issue with the cross matching. Then we repeated the blood grouping, where we found to be during on forward grouping, it was O positive, but on reverse grouping, it was AB positive. So it was inconclusive. Hence, whenever we are giving the bloods, if we are giving the PRBC, we are giving the O positive, and if you are giving the FFP, we are giving the AB positive blood group. And gradually the transfusion requirement was decreased, and in the last 2 weeks doesn't require any transfusions. And patient was discharged on day 86 in a stable condition. During the follow-up in the on day 130, we again repeated the blood grouping and also salivary grouping, which was suggestive of AB positive again. Learning points from this case were prolonged serositis in this patient was due to the combination of severe dengue, hospital-acquired infection, and sepsis-associated HLH. Switch in the blood group in this patient can be due to the multiple transfusions. And if you are dealing with a patient who received multiple transfusions outside the hospital or requiring the multiple transfusions during the hospital course, reconfirming the blood group must be considered for the safety of the patient and to prevent the transfusion-related side effects. And this is the one case report in the Annals of Laboratory Medicine, where there is a switch in the blood group after a massive transfusion. It is a surgical case with abdominal and chest trauma, and ours is a medical case. The second case was 19-year-old male, known case of bronchial asthma with a past history of hepatitis C and COVID-19, presented to the hospital with the complaints of fever, yellowish discoloration of the skin and eyes, and headache. And on evaluation in the day 10 in the SGPGIMS General Hospital, patient had elevated bilirubin and severe transaminitis. And on the same day, patient was admitted in the SGPGIMS emergency department on day 10 and evaluated for the viral hepatitis, and supportive treatment was initiated. On day 13, patient had a confusion, slurring of the speech, and irritability. Hepatic encephalopathy was suspected. Patient was shifted to CCM ICU on day 13. Issues at admission were acute liver failure with grade 3 hepatic encephalopathy, coagulopathy, and respiratory failure. SOFA was 8 and Apache score was 12. Provisional diagnosis at admission was acute liver failure under evaluation. The probable etiologies considered were viral, tropical, autoimmune, and Wilson's disease. On the first day of admission, in view of hepatic encephalopathy and suspected cerebral edema, patient was intubated and NCCT was done, which was suggestive of cerebral edema, and neuroprotective measures were continued. In view of elevated ammonia and acute liver failure, NSTL cysteine therapy was initiated. During the next week, there is a gradual decrease in the saturation levels and with decrease in PF ratios. And then HCT done, which was suggestive of a bilateral consolidation, and lung protective ventilation strategies were initiated. Meanwhile, the workup for the hepatitis was came out, and on viral panel, hepatitis A virus IgM antibody was positive, and autoimmune hepatitis was negative, and low ceruloplasmin and high urinary copper was noticed. And for suspected Wilson's, we started on zinc estate, and 5 sessions of plasmapheresis was done. And with this, we are expecting some improvement, but here the real challenge comes. And here you can see the series of organ involvement, and each one aggravates the other and creating a vicious cycle, which is more worsen than it looks. And let me explain. On the background is this acute liver failure. Patient already had a raised ICP with raised optic nerve sheath diameter, and gradual worsening of these oxygenation issues, and with severe hypoxemia with PaO2 FiO2 ratio of 52. And apart from that, patient also developed a shock and acute kidney injury. Both of these conditions will worsen the cerebral edema and severe ARDS. And here, even after optimization of all these organ failures, still we are having severe hypoxemia, and finally we are left with nothing but the proning. But proning can improve the ARDS, but it can worsen the raised ICP and cerebral edema. And hence we have gone through the literature, and we have noticed proning with head and position. Here you can see the proning with head and position of around 11 degrees, and we did 2 sessions of proning in this case. And gradually over a period of time, patient edema was resolved. Other organ supports also decreased, and patient was discharged in stable condition on day 49. And during the follow-up, the whole exam sequencing was no abnormality was detected for the Wilson's disease. The learning point from this case was prone ventilation with a head and elevation with a continuous neuromonitoring could be considered in a severe ARDS despite raised intracranial pressure. And here is one systematic review in a critical care medicine society in a proning position in neurologically critically ill patients, where one randomized control trial and the few cohort studies were published, where the head and elevation was done around in the range of 10 to 20 degrees. But here all these cases are the surgical cases like a traumatic brain injury and other hemorrhage in the brain. Next 2 cases will be presented by Dr. Tinu.
Good morning all. Coming to case number 3. He was a 54-year-old male patient visited to private hospital with the complaint of mild to moderate grade fever, joint pain with malaise, vomiting for 4 days, ascending and progressive weakness for 1 day. On examination, initial blood pressure recording was systolic 200, diastolic 110 of mm of Hg. So NCCT was done to rule out hemorrhagic stroke. That was normal in study. But on day 5, patient had a witnessed choking, respiratory distress, and altered sensorium. So in view of respiratory distress and altered sensorium, patient was intubated and continue on mechanical ventilation. But patient is continued to have ascending progressive quadriparesis. On examination, patient is having a power in upper limb and lower limb 0/5 with absent superficial and deep tendon reflex. Patient become anuric on day 16. In view of ascending progressive quadriparesis and absent motor and sensory reflexes, on day 28 nerve conduction study was done, which was suggestive of Guillain-Barré syndrome. But there was no resolution in symptoms. So on day 31, patient was shifted to our department with the issue of flaccid quadriparesis, moderate ARDS, and acute kidney injury stage 3. At the time of admission, SOFA was 11 and FHA was 28. During course in CCM, patient was having normal higher mental functions, but continued to have flaccid quadriparesis, hypotonia, absent superficial and deep tendon reflexes, and sensory loss, food touch, pain, and temperature. During investigations on the day 32, patient was having a very high total creatinine phosphokinase that was near about 22,390 international unit per ml. But during next course of 1 week, it came to a normal limit. During tropical workup, patient was found a chikungunya IgM positive. CSF analysis was done, which was showing no albuminocytological dissociation. CSF culture was sterile. However, electro EMG and nerve conduction velocity testing was not possible due to generalized edema and the hemodynamic instability. But there was continued flaccid quadriparesis and absent reflexes. So on day 72, MRI brain with spine screening was done. In MRI, brain was normal, but in MRI spine, on T2 FLAIR sagittal view, there was a subtle hyperintensity lesion in cervical cord and the dorsolumbar regions, which was extended up to conus. Even same seen in the axial view with the hyperintensity lesion in the lumbar and thoracic levels. On day 100, patient regain sensation, food touch, pain and temperature in upper and lower extremities. But on motor examination, upper limb was showing a 1/4 5, and on lower limb, motor power was 0/5. So again, on day 119, nerve conduction study was done, which was showing absent response. And on electromyography, it was showing mild fibrillatory activity. So there was a diagnostic dilemma in this patient. That patient, based on the clinical history and on the neurophysiological study, it was suggestive of Guillain-Barré syndrome. But on radiological findings, it was suggestive of long segment transverse myelitis. And part of anuria, patient continued to manage with the intermittent hemodialysis. But on day 120, patient started passing urine. Learning point from this case that chikungunya associated neurological complications are rare but severe in nature. Chikungunya associated long segment transverse myelitis has been reported in literature. By one case report is there by Sajid Hamid that was showing that chikungunya virus infection is not always a benign condition. It may present in various neurological complications. And steroid have good results in the management of chikungunya associated transverse myelitis. And chikungunya associated acute kidney injury has been reported in the literature and it has a better outcome. As one case report reported in American Journal of Kidney Disease. Coming to case number 4, he was a 33-year-old male, previously healthy, presented to he was having a mild to moderate grade fever, a small furuncle on the left paramedian angle of the abdomen for 9 days, diffuse dull pain over the abdomen and lower back, and bilateral knee joint swelling and the pain. He was at home, and on day 10, he presented to emergency department in view of a gradual increase in the size and laceration of furuncle, abdominal pain which got worsened, and bilateral knee joint pain and swelling also increased. On in emergency department, USG abdomen was done, which was showing multiple liver abscess, and HbA1c level was detected as 9.4%, which was showing poorly controlled glycemics. In emergency department on day 10, NCCT abdomen was done, which was showing multiple liver abscess with base safe splenic infarct. MRI of knee joint was done, which was showing mild knee infusion with osteomyelitis of femur and the tibia. IV empirical antibiotics was started here, but there was no relief in symptoms. On day 20, patient condition got worsened and started having shortness of breath. Non-invasive ventilation was started, and on day 21, patient was shifted to our department with the issue of hypoxemic respiratory failure, bilateral knee joint pain and swelling, and severe abdominal pain. At the time of admission, patient was having SOFA 4, FHA 11. On day 21, in view of worsening of respiratory distress, patient was intubated and continued on mechanical ventilation. Culture was sent, and on the same day, HRCT thorax was done, which was showing a bilateral consolidation with air bronchogram with multiple conglomerate nodules. In blood cultures, Burkholderia species was detected by Maldit-Toff techniques. In synovial fluid, Burkholderia pseudomyeli was detected by the Vitek-2. So patient was diagnosed as a case of melioidosis. Managed with the IV doxycycline cotrimoxazole, patient shown an improvement, and on day 27, patient was extubated. And on day 42, patient discharged with the oral cotrimoxazole for 6 months. Learning point from this case that in such a patient, the usual clinical diagnosis is gram-positive sepsis, usually by Staph aureus. But melioidosis is an emerging infection and should be considered in such patients. However, Burkholderia pseudomyeli is difficult to recognize with the Maldit-Toff techniques, but can be identified with Vitek-2 method. So closed loop communication between treating clinicians and microbiologists should be necessary. Next 2 cases will be presented by Dr. Deepika. Thank you.
Good morning, everyone. Here I present a case of 26-year-old female who was previously healthy. She came with complaints of fever for 2 days, pain abdomen for 2 days, and vomiting for 2 days. Fever was high grade, associated with excessive sweating and chills and rigors. Pain abdomen was dull aching in type and in the periumbilical area. Vomiting was non-projectile, non-bilious, and contained food particles. There is no significant negative history associated with these symptoms. With the above mentioned complaints, patient went to a private hospital and she was there for 3 to 5 days. And she was tested positive for dengue NS1 antigen, and IgM was also positive. She also had transaminitis. Ultrasound abdomen showed mild ascites with bilateral pleural effusion. As there was no clinical improvement, they shifted the hospital where she stayed from day 5 of illness to day 23. During the course, she developed shortness of breath, requiring oxygen therapy. In view of respiratory distress, she was intubated on day 60 and she was also tracheostomized on day 23. As there was no clinical improvement, she came to SGPGI, and at admission, she had encephalopathy, circulatory failure, circulatory shock, severe ARDS, and fever. Her SOFA was 9 and Apache was 22 on admission. During the course in CCM, sedation was continued with intermittent sedation breaks. Persistently, her GCS was E1, VT, and M3. Initially, she required vasopressors, which was gradually tapered and stopped. Patient intermittently had tachycardia and bedside echo was normal. She presented to us with severe ARDS requiring 4 sessions of pruning. She tolerated enteral feed, moved her bowels regularly. She passed adequate urine output. Urine output was adequate and she was never dialyzed. Intermittent fever spikes were there and was treated according to culture and sensitivity. On day 49, we had stopped her sedation and over 120 hours since there was no clinical improvement and also there was went ahead with MRI. Her MRI brain showed hyperintensities in the bilateral basic ganglia on T1 flare and also on T2. On single weighted image showed anterior commercial bleed and also splenial bleed. In view of high-grade fever spikes, tachycardia, tachypnea, and systolic hypertension, a thorough workup for fever was done. Both infective and non-infective causes of fever were ruled out, and hence paroxysmal sympathetic hyperactivity was suspected. There is a diagnostic scale which takes into consideration the clinical features and its severity, and diagnostic likelihood tool which takes into consideration the episodes of paroxysmal sympathetic hyperactivity, the intensity and the duration, and the score calculated by adding sum of these scores. If the patient has more than 17, then he is suspected to have probable paroxysmal sympathetic hyperactivity, and in our case, the score was 24. And hence, specific therapy with tablet clonidine and propranolol was started. Post starting therapy, we can see there is reduced and decreasing trend of temperature, heart rate, and there was no much change in the mean arterial pressure. So dengue and paroxysmal sympathetic hyperactivity. PSH has been reported in acute brain injuries and rarely in viral encephalitis. Dengue fever is an unusual etiology of hemorrhagic encephalitis and microbleeds, which is attributed to neurotrophic nature. Strategy of the treatment is to prevent and control excessive sympathetic activity and its consequences by early diagnosis and specific therapy. Even then, the patients are left with permanent disability secondary to spastic stiffness, body malpositioning, and profound neurocognitive disturbances. Hence, PSH is a diagnosis of high clinical suspicion and diagnosis of exclusion. Coming to my next case, here is a 9-year-old male child who was previously healthy, presented with complaints of high-grade fever, vomiting, and passage of cola-colored urine for 1 week. He presented to the ICU with above-mentioned symptoms, and on investigation, he had severe anemia with raised LDH of 7,000, hyperbilirubinemia, and he also had deranged RFT in the form of raised bilirubin, BUN, and creatinine. For workup of hemolytic anemia, peripheral blood smear was done, which showed polychromasia along with basophilic stiffling. Hemoglobin analysis was done to exclude hemoglobinopathies. G6PD enzyme levels were done, which was grossly low. And at admission, tropical fever workup showed leptospiral IgM positive. Hence, a diagnosis of acute hemolysis associated with G6PD deficiency, probably triggered by the high oxidative stress provoked by leptospiral infection, was made. During the course in ICU, in the second week of ICU stay, patient developed epigastric pain, which was progressive, and his lab report showed raised serum amylase and lipase. Ultrasound abdomen showed edematous head of pancreas and hence a diagnosis of acute edematous pancreatitis was made. He was managed conservatively by blood products, hydration, broad spectrum antibiotics, antipyretic, and antiemetics. He also received 1 session of renal replacement therapy in view of uremic encephalopathy. He responded clinically in the form of decreasing level of serum bilirubin and creatinine. There was visible improvement in the high colored urine to normal straw colored. Hence, he was discharged in stable condition. And a final diagnosis of acute pancreatitis due to massive hemolysis in a child with G6PD deficiency with leptospirosis with AKI was made. The incidence of pancreatitis in severe hemolysis is said to be 25%, and the underlying pathogenesis still remains unclear, and the possible postulates were large amounts of free heme aids in the formation of reactive oxygen radicals and causes leukocyte recruitment, activation of the coagulation cascade, forming microthrombi and damaging the vascular integrity of the pancreatic microvasculature. Free heme inhibits endothelium-derived relaxing factors, causing local vasoconstriction. Leptospira per se can cause acute pancreatitis, and it usually presents in the first week of illness, unlike in our case where he presented in the second week. Next would be demographic data of our ICU by Dr. Aman.
Good morning, everyone. So the data which we are presenting has been collected from January 2019 to December 2022. Total patients of topical infection admitted in CCM during this duration was around 82 out of 892 total admissions. So percentage was around 9.2% of topical infection patients admitted. Topical infection cases admitted overall in Indian ICUs as per INDICAPS 2 study was around 2.9%. Caseload of topical infections in CCM. Here in this graph, we can see that dengue is represented by blue color, chikungunya by yellow color, scrub typhus by gray color, malaria by yellow, and henceforth melioidosis, hepatitis A, and hepatitis C. As we can see that over the years, the number of cases of dengue getting admitted in CCM is increasing, along with cases of chikungunya, scrub typhus, melioidosis, malaria, hepatitis A, and hepatitis E. Coexisting tropical infections, dengue with leptospirosis, we had 2 cases. Dengue with scrub typhus, we had 1 case. Leptospirosis with scrub typhus, 1 case. Dengue with chikungunya, 1 case. Dengue with chikungunya with scrub typhus, 1 case. HLS cases among topical infection patients. Hemophagocytic lymphohistiocytosis confirmed 6 cases. Total incidence was around 7.3%. 2 patients received IVIG, and the mortality rate was around 66.7%. Age distribution of total number of patients admitted, topical infection patient admitted in CCM. Here in this graph, we can see that these are the age distribution of the patients. The blue bar represents the total number of patients admitted in CCM, and the orange graph is representing topical infection cases admitted in CCM. As you can see that the maximum number of cases admitted of topical infection CCM belong to age group of 11 years till 50 years, which represent the most productive years of life. Male to female ratio wise, 66% patients were male and 34% patients were female. Socioeconomic status wise, 59.3% patients were belonging to middle socioeconomic status, 33% belong to lower socioeconomic status, and 7.4% patients belong to upper socioeconomic status. As far as cohorts of the patient from where we received our topical infection patients, maximum number of patients were received from district of Lucknow, that is around 28 patients. From Allahabad, we had 15 patients, and from district of Kanpur, Hardoi, Barabanki, we had 4 patients each. From our neighboring state, Bihar, we had 3 patients of topical infection admitted in our CCM. Comorbid illness wise, as you can see here, that around 38 patients had no comorbidities and 44 patients had some or other comorbidities. Hypertension, 15 patients, diabetes mellitus, 13 patients, hypothyroidism, 8 patients, and post-COVID chronic kidney disease, chronic heart disease, chronic liver disease, and stroke among various frequencies in the patients admitted in CCM. Admission source. From outside, we had around 45 patients, emergency department, 18 patients, other ICU, 16 patients, and from various other wards of SGPGI, 3 patients. Organ failures at admission. As you can see here in this diagram, that more than 80% of the cohort of the patients admitted in CCM with topical infection had 2 or more organ failures. Organ failure severity score at admission. Median Apache score was 18.3 and median SOFA score was 9. Median Apache 2 score and SOFA score of INDICAPS 2 study was 16.9 and 4.4 respectively. Major organ dysfunction during ICU stay. Pathophysiology wise, 41 patients had encephalopathy, out of which 13 required neuroprotective measures. 49 patients had hypertension, out of which 11 were managed with fluid restriction alone, while 38 patients required vasopressin during some point of their ICU stay. 16 patients had acute respiratory distress syndrome, out of which 5 required proning session. Mechanical ventilation wise, total 46 patients received invasive mechanical ventilation, out of which 17 patients require non-invasive ventilation also. This mechanical ventilation per se was instituted for lung pathology as well as for rapidly worsening encephalopathy, rapidly worsening hypertension, and rapidly worsening severe metabolic acidosis. As far as acute kidney injury is concerned, 48 patients had acute kidney injury, out of which 21 were managed with conservatively, and rest required some or other form of modality of renal replacement therapy during their stay in CCM. 52 patients had hepatic dysfunction, out of which 2 required plasmapheresis. Overall, 46 patients received transfusion, and as you can see that the maximum number of transfusion requirement was around 35. Length of stay in ICU. Median stay was around 8 days. Maximum stay was around 120 days. This patient is still ongoing. Outcome wise, out of total 82 tropical infection patients admitted in CCM, 52 were discharged. 1 patient is still outgoing, and 2 patients were discharged with vegetative condition. Total mortality was 29. So we can see here that around 64% patients were discharged, and mortality was around 36%. Overall mortality in Indian ICU as per INDICAPS 2 study is around 18.5. Next presentation will be done by my colleague, Dr. Shraddhanjali.
Good morning, everybody. Today, I will go through the review literature part on tropical disease in ICU. Tropical diseases are unique to the geographical region close to the equator because of warm climate, heavy rain, high humidity, and dense forestation, and increased population pressure leads to deforestation and urbanization. All these factors contribute to the increased proliferation of insect vectors, which is responsible for human to human and animal to human transmission of tropical diseases. These are the list of tropical diseases with modes of transmission. There are 4 modes of transmission. Out of these, vector-borne and food and waterborne are the most common modes of transmission. Among the vector-borne, mosquitoes, ticks, fleas, and sand flea are the most common factors that are responsible in causing tropical diseases. Common causes of tropical illness that leads to ICU admission are dengue, malaria, leptospira, rickettsia, diarrheal disease, and typhoid. As per the INDICAPS 2 study, it has been seen that among Indian ICU, 2.9% of the patients have admitted with tropical infection, and mortality among them is 18.5%. Public health measures like sanitation, vector control, and immunization, along with provision of the critical care, is often challenging in some countries. That mainly attributes to high mortality, and it is attributed to the cause of tropical disease-related mortality. If you see the global disease burden cause-wise, though the non-communicable disease contributes maximum case burden, both in the worldwide and also in India, followed by communicable disease, malaria and neglected tropical disease accounts 2.5% worldwide, and in India, it attributes 1.3% in the India. If you see the trend of the tropical disease burden in the last 3 decades, from 1990 to 2019, malaria and neglected tropical disease, which is depicted in the orange shade, the disease burden has been significantly reduced in the world from 900 million to 500 million. Also, the same is seen in the India. The burden has reduced from 250 million to 125 million. Then comes to individual tropical diseases, that is dengue in the Southeast Asia region. If you see the trend from in last 3 decades, incidence wise, the incidence is gradually increasing, though the case fatality percentage rate is decreasing, but the estimated disability adjusted life year, that is DALY, which signifies the morbidity, which is the trend is shows increasing trend. Then comes to the trend of dengue cases of India. If you see the India map in the globally, as per in the 1990, how hypoendemic it was, but by the end of 2017, India became one of the hyperendemic zone in the world map. Dengue case burden in India, if you see, it has been divided into 3 zones as per the caseload, that is high burden zone, moderate burden zone, and the low burden zone. Out of 36 states, including 7 union territories, 15 states are included in the high burden zone, and where all 4 serotypes are seen. And Uttar Pradesh is coming in one of the high burden zone in India. If we see the contribution as per the zones, maximum case load was from the high burden zone. We can see that the orange bar in that is showing trend from the 2000 to 2019. It contributes 83.4% only, that is from the high burden zone. And also the same that dengue related deaths are maximum from the high burden zone. We can see that it accounts for 82.3% of the total dengue related deaths in India. The risk factors for ICU admission and mortality are high SOFA score, high Apache score, high arterial lactate, low serum albumin, involvement of the organ system are more prone to have high mortality risk, as per the study published in the 2016. These are the literatures on dengue in ICU from different zones of the world. This shows that the case mortality may be as low as 6.1% in one of the study published in 2011 to as high as 29.6, which was published in 2012 from the Sri Lanka. Next, come to another tropical disease, that is scrub typhus. It is endemic in the Asian Pacific region, which is traditionally known as Susugamushi Triangle, which is bounded by Japan, Australia, and the Pakistan, where maximum number of cases and outbreaks are seen. Though origins are also seen countries other than this triangle also. And patients admitted with undifferentiated febrile illness, out of which 19% is contributed by the scrub typhus, which is seen in one of the studies from 2018. And if it is untreated, the case fatality rate may be as high as 30 to 70%. These are the literatures on scrub typhus from different zones of the world. Some are retrospective, some are prospective studies, and they have taken different organ failure severity. And it has been seen that the mortality may be as high as 24% from one of the study from India, which is published in 2014. And another study shows, recent study from Australia shows the mortality was 0%. Next, come to another tropical infection, that is Leptospirosis. It has 10 pathogenic species with more than 250 pathogenic serobars, and more than 1 million cases occur worldwide annually with a mortality of 60,000 per annum. And it has a case fatality rate of 5 to 15% with severe illness. And with severe pulmonary hemorrhagic syndrome, the case fatality may exceed up to 50%. And outbreaks usually occur during rainy season and during floods. This is the graph, global map showing endemicity zones of Leptospirosis, that is red zone areas, with some outbreaks occurring other than these red zones area in the world. And in India, the Leptospirosis case burden is maximum seen in the south and west region of the India, with a positivity rate maximum in the South India, that is 25.6%. These are the literatures on Leptospirosis in ICU, and most of them are prospective and multi-center studies from different parts of the world, taken into variety of severity of illness scores. And it has been seen that the maximum mortality was 52% in one of the study from India, published in 2004. And the recent study published from Thailand in 2020, the mortality was 4.3%. Next, come to another tropical infection, that is malaria. Globally, we can see that malaria case burden was maximum from the Africa. It accounts 82%, followed by Southeast Asia 10%, and the rest of the world contributes 8% of the total burden of cases. Same wise, death due to malaria Maximum contribution was from Africa, that is 95%, followed by Southeast Asia and rest of the world 2.5% each. If we see the trend of the malaria in the Southeast Asia region, both incidence-wise and the mortality-wise, the trend is decreasing since last 2 decades with some ups and downs in between. But since 2015, the trend is showing significantly decreasing both in incidence-wise, also in the mortality-wise. Out of 9 malaria endemic countries in the Southeast Asia region, if you see that, and India only accounts 79% of the total malaria cases in the Southeast Asia region. These are the literatures on malaria in ICU. If you see that, Africa, some are retrospective studies from different parts of the world, and the case fatality rate was 60% in one of the study from Africa, which is published in 2007. And the recent study from Oman, which is published in 2019, shows that mortality rate was 0%. And co-infection often occurs in the tropical regions. It is an emerging phenomenon, and it is because of maybe same vector-borne infection causing disease, like mosquito can cause malaria, dengue, chikungunya at a time, and occurrence of disease in the same season, and overlapping clinical features. And cross-reactivity can occur while doing the single-point serological testing, which can be further confirmed by the PCR-based molecular assay. These are the literatures on co-infection of tropical infections from different zones of the India. Some of the case series and some are case reports published in different journals. These are the studies from SGPGI on tropical infection. Since 1998 from different departments pertaining to their respective subjects. Some are case reports, some are prospective studies published in different index journals till 2021. I might have missed some literatures on this tropical infection. For that, I am apologizing. With this, I am concluding this session, tropical infection in ICU. And on the behalf of CCM department, I would like to acknowledge these departments. Thank you.